Hello and welcome to the quest for the good life with our host, Dr. Mike Strauss. He's in the house wearing, as usual, his trusted fedora. He is our adventure positive scientist, leader, and archaeologist of best practice. In other words, he's the Indiana Jones of good life innovations. We also have with us today the executive director of Good Life University, the great Megan McKinney Todd, who reminds us inconspicuously of the fierce Joe Marsh of Little Women. We have right next to her our director of technology and wizard of the digital Oz, David McDonald. And we have on the panel again Abby Baden, director of Johnson County Neighborhood Network and Safety Net. Rumor is that her versatility and professional flexibility are the inspiration behind Elastigirl from The Incredibles.
Yeah, that was last week. I'm saying that she's Samantha Stevens for Bewitched.
That's right, because she
do
can
it.
do that trick with the nose.
She can do that nose trick. And, the topic today is bewitching services, and she's kind of the head witch.
I'll take that.
Yeah.
Yes.
I think Megan's more that Glinda witch in the bubble, that floats around.
That's right.
But, Abby's a real deal. She's
Yes, she definitely is.
Yeah.
You've got me, your co-host with the co-most, Ivo Ivanov. And, last episode, Dr. Strauss mentioned that we discussed how to achieve independence without sacrificing safety and privacy. It's the essence of the privacy paradox, and it has been a bewitching problem. So I wonder if Dr. Strauss can remind us a little bit about last episode and the conclusions.
I don't usually like to do it, but these are such related episodes. And so I'm going to do a little mini baby review, but may I just say, if you haven't watched the last episode, you have to watch that. We're going to really talk about the Neighborhood Network this episode and how we really kind of created bewitching services from the ground up. The essence of the privacy paradox, Evo, was that, in our attempt to protect privacy, we've restricted or dismantled less intrusive processes compared to traditional services that we've actually hindered our ability to advance best practice, where we are achieving goals of independence and self-direction, autonomy, personal safety, accessibility, all the really critical goals, including privacy. We were actually hindered our ability to advance privacy based upon our way we try to protect privacy, which is crazy. One of the critical things when we're trying to advance care is trying to figure out what are our most expected outcomes. What's the goal of care? We really focused on 5 federally protected outcomes or expectations of care. These are the big ones. They're grounded in ADA and IDEA and Olmstead and final settings rule. I mean, this is where, our human rights have shaped the goals that we are to deliver. And as we design our care system, number one in my heart is help people live as independently as possible. And independence doesn't mean free from help. It just means, it's a way of life. It's being responsible for yourself and your own actions and in charge of your own destiny, making your own decisions and living a life as close to what other people can live as possible. Independence. In a way, we're a little interdependent to be independent, right? We need some level of that. 2, second goal is empowering greater self-direction. Now, self-direction, as a behavioral analyst, I've always said this. You guys all know I say this all the time, that the one skill that you can teach somebody to help them be more independent, safer, and live a better life is to know when and how to ask for help. If you don't know when and how to ask for help, and you can't get the help that you asked for, then you can't live with great independence. But we want to empower self-direction and autonomy, self-governance. We want to fuel that forward. That's an expectation of how we deliver care. Independence, self-direction. We want to cultivate those skills. Third is providing access. Now, look, a lot of people don't have access to what they need to live with greater independence. You need to have access to staffing supports and support. You have to have, number one, you got to have access to the help you need, right? One of my big pet peeves is that people can't afford good housing in good neighborhoods. And so that puts them out of accessing really important things that they can't access because they're confined to be in substandard housing, in substandard neighborhoods, in substandard communities. And that's regrettable. Some people who have very complex needs don't have access to living independently because they don't have the accommodations of the housing and some of the other supports that they need. They just don't have it. Another goal is personal safety. Obviously, if you don't feel safe, then you can't, live your life normally. People shelter themselves if they don't feel safe. And then finally is privacy. Privacy is having, being free from invasions of privacy when privacy is most expected. But if your son who's being deployed overseas maybe right now calls you during dinner, I guarantee you that's not an invasion of your privacy, is it? But what if the salesman does? Well, that is, right? So the reality is privacy sort of is, you got to put the welcome part. If somebody needed help in the shower because they needed physical help in the shower, that's pretty intrusive. We'd have to admit that's pretty intrusive, right? But if it was welcomed, it's not an invasion of privacy. It's only an invasion of privacy if it's not welcome. So, and I will tell you this, there is no method of care that isn't an invasion of your privacy. All care is invasive. Some are more so or less so invasive. But that's true for every one of these 5 goals, guys. All 5 goals, our care approach will either advance them more than other approaches. And our goal is to pick the one, the care strategy that can advance our goals better than any other alternative option, right?
Yeah.
And that means advance all of them. But if we just focus on one goal and we said, look, the only goal here that matters, none of these others matter. The only one that matters is privacy. Well, I can fix that. Just don't give any care at all. Right? They don't mean that. So privacy isn't something that prevents you achieving care expectations, goals. It's just something that you balance and you pick the approach that can push all of these forward. Not one of them, but all of them. They're all federally protected, and there is nothing that I know of by federal regulation that says one is supremely more important than anything else. We're to balance them and push them all forward as best we can and pick the strategies to do it the best. That's what we do, right? So the reason I went through all of that is the only way that you can pick the one that advances it the best is if you compare it to something you would use otherwise. Like, how would you know, Megan, that you're advancing the best using this strategy unless you compared it to something? Those outcomes that we talked about, we are to use the least intrusive method possible that can most effectively or best advance required and the most critical care expectations. So we're to use the least intrusive approach to advance all of those care expectations the most. That's the job. And you know what? Anybody I've talked to agrees with that. I have never talked to anybody that doesn't agree with that. The irony of ironies is all the policies I read don't even have that requirement in it. All they're doing is they're giving you concept ideas about how you should restrict this or you should restrict that, but they're not comparing it to anything. And they never compare it to what would be done if you didn't do it. So the reality is our job isn't done unless we do this. And to do that, we have to compare what we're proposing to do with what would be done otherwise or no care at all. In science, medical science in particular, over time, you figure out which one advances your care expectations the most. And it becomes in a hierarchy higher than another procedure that maybe used to be used that doesn't advance it as well. So once you make these decisions over and over and you find out one is always less intrusive than the other, the truth is that should be above the other one, and you should try this one first. Well, if two procedures aren't clearly one less intrusive than the other, then personal choice should fall right into that. We should be able to choose, right? When you're choosing between care approaches, it's important to be clear to the people you're working with and give them meaningful choices. And it's not one-sided choices. You wouldn't give a choice like, hey, should we use remote support? That's not a choice. That's a statement. A choice is, should we do remote support for this specific need, or should we do nothing at all? Or should we do remote support for this need, and should we do in-home support? That's a choice, right? But now you have a choice that you can look and compare them on intrusion, on how well they achieve the goals, all those sort of things, as long as you have a choice. But if you don't have a choice, you can't compare anything, right? So I give the example of my father, who's no longer with us, but I can guarantee you in the last few years of his life, when he was really having struggles living independently, if I asked my father whether he would prefer to have somebody in his home, he would just say, no, I don't want anybody in. That's one-sided choice, right? You want somebody in your home to help care for you? No, don't want that. Okay, well, what about this? Would you rather go to assisted living and get support, or would you rather have somebody in your home? Now we got something to talk about. The first one was not realistic because he needed some help. So it wasn't realistic to say, would you like somebody in your home to help you or not? Because the or not wasn't going to work, right? It wouldn't advance his goals of care. So the choice could be like in somebody in your home or go to assisted living, or it could be choice two, pressing the help button for remote help and then choosing between remote or in-person help each time you press the button. Or would you rather have somebody in your home waiting for you to have a need? Well, I know what he'd pick. He'd pick, the first one. And would you rather have a remote video visit with your doctor or a nurse for a weekly follow-up care, or would you rather travel to the clinic? Well, he'd rather have a phone call. Literally everybody that I know would pick the ones on the left. And by the way, if you pick the ones on the list every time and 100 times you ask, that's a care hierarchy. You've now created your own care hierarchy because that one's demonstratively less intrusive on that. And by the way, I always like to have a warm-up question when I'm out doing conferences. I always say this: would you rather have a remote meeting with your boss, or would you rather have your boss come into your home to meet with you? And they go, well, why would you do that? I said, well, that's just kind of like, that's actually the choice of care, right? Would you have a remote support, or would you rather have a care person come in your home? Well, who would want their boss to come in their home, right? Nobody does. I'm just illustrating that we really do have hierarchies here. We're just ignoring them because we've never actually chosen between them. We actually have created hierarchies. Here's the first one. So remote assisted living and smart home methods of support appropriately designed are less intrusive and more private than traditional in-person care, presuming that both approaches can meet the same need. You can take that one to the bank. Next one, self-detected needs are less intrusive than sensor software detected needs. But that sensor software detected needs are less intrusive than caregiver detected needs. I can prove that and did. That's a hierarchy. Next, organic choice is less intrusive than a priority choice, or what I call one and done choice. One consent saying, I want this, but not that. Versus every time you have a need, you get to choose what you want. And I give the example, when you get up, Abby, every day and you look at your schedule, you can say, hey, I have 3 different people I have to meet with, but I really know these 2 people well, and they're pretty far from here. I'm going to do that remote. And this one, I'm going to do in person. Like, you make these decisions organically every day on how you live your life, right? All the time, based upon what is less intrusive for you, right? Organic choice, meaning making choices on the fly and then actually remaking them differently the next time. You can, same circumstance. I'm just having a bad hair day. I'm not going to get dressed up. I'm not going to go out. The weather's bad. There's so many factors out there that you want to change your mind. And I've heard that people like to do that. That's another one. Finally, settings matter. What's the setting rule really about? Well, the setting rule really about is living in smaller, more typical, inclusive settings, right? As setting sizes get smaller, they are more flexible. They have so many more attributes. They have so much more potential, certainly more privacy. You go to congregate care, well, you lose a lot of privacy. You lose a lot of flexibility. Smaller settings are less intrusive than larger ones. So that's kind of part of the review, but all an assisted living facility really is a way to organize a care for people who are mostly independent. It's to organize care. They created a setting to organize care. And I can tell you, having led the closure of roughly 6 institutions in my 40-year career, I can tell you the number one reason why an institution exists is to organize care. I mean, nobody wanted to live in the institution, but it was organized. The reasons you have a clinic is to organize care, right? Settings organize care. So when you're wanting to go to a small setting, you lose the ability, if you do it traditionally, on how you organize care. And when you do that, you lose a lot of capabilities, like organized care versus one home care. One home care has lots of problems to it, like if somebody doesn't show up, or how do you support somebody who has a complex care need when the DSP there doesn't know how to do it? In a large setting, you have a nurse that you can deploy. You have an experienced staff person to help somebody who is new. You got a supervisor on there. So, this kind of slide talks about why congregate care exists. Nobody really wants it, but there are functions of congregate care. When I closed the institution, my whole goal was how could I deliver those functions in small settings? We created the neighborhood network to overcome all those obstacles and to advance care expectations the most possible we could in the least intrusive way possible. The neighborhood network was sort of created to advance 2 things: the care expectations for the people we serve in the least intrusive way possible, while also advancing the quality of life of the people, the DSPs and others, who made that mission possible. It was designed to advance both people's lives. We wanted both groups to have a good life. The neighborhood network, is pretty cool model, and it's award-winning. Megan, what awards did we get with this one?
Yeah, so there's actually 2 of them that we know of in our lifetime, at least so far, the iteration of the Neighborhood Network. It won the Moving Mountains Award from ANCOR, the National Association of Direct Support Professionals, and the University of Minnesota. And before that, and Mike, actually, this was before my time, so I might get the quote wrong, but I think it won an international award essentially for best or most promising service delivery
most
model.
innovative service model. And what I'm proud of about the Moving Mountains Award is because of this collection of people. Like Minnesota was a research and training center on staff stability. That's really where its heritage was from. All the 40 years of research on turnover came from the University of Minnesota. The National Association of Direct Support Professionals, obviously that was the people that we really want to help. the people that make our mission possible. And Anchor pushed forward like the impact on persons served. So, that was such a special award and what I loved about it is it won the award that it was designed to win. Really, it was. So very proud of that. So we were trying to reimagine independence with the neighborhood network. How I'm really going to describe it is it's care as an amenity of a normal neighborhood, right, Abby? I mean, we picked a normal neighborhood and we designed a care system. What we were destined to do was to say, look, we may not have an assisted living facility, but we have a neighborhood. And instead of looking at designing care per home with all the flaws that come with it, why don't we organize the care of a neighborhood and deliver it to need organically as those needs ebb and flow, just like they could a facility, but without the facility, right? I mean, that's it in a nutshell. And then how can we improve the stability of staffing and improve their lives too? Well, we invented professional neighbors and other kinds of strategies so that, the people who cared for the people that were lived in that neighborhood were also living in that neighborhood. So it was an incredible, and we designed that, I think, in 2010. But this is where I want to go back to Bewitched. The whole point that I've used in the title of Bewitching Services is about my sort of heritage with Bewitched and Samantha Stevens, where if she needed something, she would twinkle her nose and it would pop there. She would get what she needed and twinkle it again and it would go away, right? And I thought, I don't know how to do it at the time when we were thinking about this, but isn't that really the way you would love to have services? If you needed services in your home, could you imagine it being better than Bewitched? I mean, I need some help, with my shower. I need some help with my food. I need some help. Somebody's at the door and I don't know who they are. I'm uncomfortable. I want somebody with me. I can name 1,000 things I might need help, but then after that, I want it to go away. I don't want it. I'm going to live my life. I don't want to go to a clinic. I'm going to wiggle my nose and have the clinic come to me. In essence, that was the goal of Amazon, Instacart, Netflix, Talkspace. I can name 100 of things that were technology leveraged things that have brought the world to us, not us to the world, right? A real proper high BHAG goal was to say, I want services to be just like Bewitched. I want to snap my fingers, get what I want, snap my fingers, let them go away. I don't want to have to, I want them to enter my world to help me and exit my world. I don't want to have to go to their world. I don't want a caregiver in my home when I don't need a caregiver. I don't want to have to entertain them. I don't want them sitting on my couch. I don't want them up at night, keeping me awake. I don't want their child coming over. I don't want them talking on the phone while I'm trying to watch this. I don't want them asking if they could watch this show instead of that show. I don't want them to use my refrigerator. I don't want them to go outside and take a smoke break and come back in and smell like smoke. I don't want any of that. Why would I want that? Why would you want your boss coming into your home to meet with you? So
I think this is I was just going to say, I think this is such a critical and important component to why the neighborhood network stands out as a next generation approach to care, because we're essentially emulating what every other industry already does. We're taking what an individual needs and wants and delivering it on demand. And when you listed all of those other companies that already do that, we're reminded, the stores are closing. We're in a space where technology now enables for what you want to be delivered on demand, streaming instead of picking out a videotape, right? And so the caregiving industry has to keep up with that, or it becomes irrelevant. And and
it is irrelevant. It's become irrelevant because we're so far behind.
Yes, exactly.
And so we started off with that goal, and I would have to say we're mostly achieving it, especially if you ask the people that we serve. Traditional care, in-home care or otherwise, isn't very friendly. It isn't very customer friendly. It isn't around our needs. We don't pop it in, we don't pop it out. We can't do that.
And what I
So-
love about this model too is it's built to give us the capacity to do whatever support was needed. And then it allows us the ability to address the hierarchy of need and then the organic choice included,
Right.
which is
Yeah.
amazing.
So what's the, we talk at a high level, what's the math problem for the neighborhood net? What do we try and do? Anybody want to just throw that?
Yeah,
Right.
I love this one. It's an equation, right? So we're taking a typical neighborhood, someplace that's already close to community amenities, someplace that's got high sort of safety standards, well-lit streets, accessible spaces, and really good amenities. We are embedding the homes within that neighborhood with iLink technologies. We're imbuing that neighborhood with direct and remote support professionals, so folks who can contribute to the neighborhood in general, but also be available remotely. And it's sort of that magical combination that allows for us to deliver need care essentially on demand within 5 minutes of need.
Yeah, and so it's an ecosystem.
Yes,
I use
yeah.
that word. It is that we've created an ecosystem of care in a normal neighborhood and have it deliver to needs remotely or in person, ebbing and flowing around those needs with the idea that we're advancing those 5 goals that we talked about earlier, including privacy, in a way that you cannot do or even approximate using traditional services. And because that's true, it's here and they're there in intrusion. But we start with a well-selected neighborhood, and you mentioned that, Megan. It was like it's one that we would want to live in. And the truth of the matter is, this is where the access thing comes in. Most people who are on public assistance are poor, and they really often can't access a great neighborhood. I will just tell you, one of the things I'm most proud of is that we are cost effective because we don't have to have people waiting for needs. We ebb and flow around needs, and we deliver to needs 24/7, but very cost effectively, to the point we can actually subsidize people and help them with their housing costs. We've lifted them up, so they are in
are
a
able
better
to-
neighborhood.
I was going to say they wouldn't be able to afford to live in these nicer neighborhoods without our subsidies.
Nope.
And what we're saving essentially is able to be returned back to the person served, and you'll see later, to the caregivers who also live in the neighborhood.
Right. The opportunities for the staff as well.
Yeah,
Yep.
access housing is one of the biggest challenges in the country. It's a challenge because we're wasting a lot of resources on how we deliver care. We're hiring a driver for everybody that needs an Uber instead of sharing that drive. Now, next we add smart technologies, and every home has I'll say smart and enabling and remote technologies added to it. And yes, it's a platform of care, just like Zoom is, just like, Uber is a platform of care, just like, EMARs are platforms of care that deliver individualized medications. And we'll get into that again, but, it's not a collection of apps. It is literally a remote support, smart home enabling platform of care that's scalable, that's teachable, that's usable, that can advance care, and you can teach people how to use it, right? So we add technologies, and and what that technologies do is it helps people learn to ask for help better, help buttons, things like that. It has sensors to help detect needs if people need that to detect needs. And by the way, people that don't think that they do, have never seen a smoke detector. Would you think we wouldn't have a smoke detector or a carbon monoxide detector or normal? We all have many of us have normal security systems, right? We want to know if there's intrusion and those sorts of things. But people with this challenges may need more ways to detect. If they can't self-direct the needs, then you're either going to do one of two things. You're going to either use sensors plus software to detect needs, or you're going to have somebody in there telling them, oh, there's a need. And we already determined that self-detected needs are less intrusive. I mean, if we detect our needs, that's less intrusive than sensor software detected needs. But sensor software to detected needs is less intrusive than sticking a person in there saying, I'm going to wait here and look at everything and then tell you if I ever see a need. That's the most intrusive, right? So obviously that's shouldn't be at the top of the hierarchy. So let's talk a little bit about iLink technologies and do a little deeper dive. And Dave, you'll probably have to say something here because you're our wizard on all of this. But
of course.
iLink Home is hardware, right? And iLink
Absolutely.
Assist is the software. It's a cloud-based software. And I always, it's so important in the design of things to make this point that a lot of people try to advance privacy on the hardware side. And that's really like a little bit Fred Flintstone-like. I hate to use that word, but it kind of is, because all the current technology that we use advances privacy at the software side. Example, I get up at night, I walk to the bathroom, I go into the bathroom, walk out, and I go back to my bed in 5 minutes. That's not a need. But what if I got up, went to the bathroom, and it didn't come out for 20 or 30 or an hour? At some point in time, that's a problem. Well, software can filter out times that I don't need help by looking at how sensors and software interact logic. I went in the bathroom, but I didn't come out. And it's going to send an alert then, but it's not going to send an alert when I go into the bathroom and come out in a reasonable amount of time and go back to bed. Well, that software is less intrusive than somebody sitting there watching me go to the bathroom and watch me come out when I didn't have any problem. Software actually advances privacy and advances independence. And it's just the software side. But the point I'm really making here is like the iPhone has 7 sensors. It has 4 cameras. You don't, Dave, do you get to pick how many cameras are in your iPhone? Well, I guess they have a model now that has just 1 camera, but I mean, when you buy a camera, you get what's in it, right?
Right,
you get
of course.
An iPhone, the sensors, it's all prepackaged. You get those whether you ask for it or not. They come in, and Alexa has 7. That my little smart ring has 7 sensors. I have a Whoop band. It's got about 1 billion sensors. Like they come with what they come with. Software decides what happens. And you wake up tomorrow and you're sick, or you have I just recently fell out of the truck and hit my head. I really did. And so like I needed a little bit more support for the following week than I do normally. The hardware doesn't need to change. It's the software that changes. So iLink technology as a platform, it has home installation. And there is some individualization of what goes in the home, but they're generally packages and designed so that we can change what is used on a moment by moment basis just by changing the software based around people's needs, because needs change, especially with seniors. So here's an example of some stuff, and I don't want to spend too much time, but we use normal things. What I love about iLink now and how it's migrated over literally 2 decades is we look and use normal things as possible as our hub of smart operations. And our normal thing that we use is Amazon Alexa Show. That's a lot of people have that. I have one in my home, and I'm not part of iLink, but I actually have 2 in my home, maybe 3. Dave, you probably have 20 in your home. How many do you have?
A ton. They're literally everywhere, outside everywhere.
So normal people have a phone. Normal folks have, Amazon Alexas. These are an infrastructure that we use and have customized for our smart home operations. We've added other things to it, but in essence, this is what people interact with. They may hit a help button. They may say, "Hey, Echo, call GoodLife." They may do some, specific things, but it's very normal. Nothing about this is really stigmatizing. Would you agree, Abby?
Completely agree. Yep.
And then we have some things you can take on the road now. This is one of our newest things. I mean, everybody knows about FaceTime, but this is kind of the next level of FaceTime for care. And we created this app. Basically, it lets you have two-way communications. But when we talk about, remember, I mentioned organic consent, being able to choose on the fly. Well, that's what I mean about our technology is like when somebody calls somebody on our phone app to remotely coach somebody, it comes across as a normal call and they have to convert it to a video call. So they get to choose that they want to have a video call by just pressing one more button, right? So let's say that you're out playing golf, you're a senior, you're playing golf and you're feeling a little lightheaded and disoriented and you really feel like you should go home. And let's say you're so disoriented, you really don't know where you are. So you make a call to GoodLife on the app, on the phone app, and you press it to do a video call with your remote coach or your professional neighbor or whoever you connected with. And you say, I'm not feeling so good. I really wish somebody could pick me up and take me home. And we say, well, hey, where are you? Well, I'm not really sure. Well, you can at their request, you can geolocate them, go pick them up. So this is an example about technology that's organic choice, but also has safety features and other kinds of things for care industry. Next, phase 2 of this is to be able to see you in this camera, but also look out the other camera. And the reason we're doing the R&D on that is because if you're using it for remote job coaching or something, you want to talk to them and see them, but you also want to see what they're looking at the same time. These are new capabilities that the new cameras have that we're kind of chasing down right now. And then, we're getting into the controversial areas of cameras in homes, but we have a camera in homes. Some of you guys are at home right now. There's cameras in homes. Never been an issue of cameras in homes. But the thing is, it's the control of the cameras in homes. Our cameras have almost 100 million gradients of privacy control. I mean, really, they do. You get to decide when somebody can come in, and they may virtually knock, but they have to let you in and agree to it. They can do old school and put a little cover over the camera if they want. And there's a speaker that interacts, with them so they can have conversations with people while they're, being taught how to make a meal, or you're going through some other things, or maybe they need supervision, just general supervision because of challenges that they may have, that they can choose to have virtual supervision over in-home supervision because virtual supervision is less intrusive than in-home supervision. And we've shown that. So this just empowers all those options, but even taking it further, we can actually go into privacy mode in these where, how you guys can pick different backgrounds for your Zoom and all that. We can literally fuzz everything so that we wouldn't see somebody, but we could see them enough to know that they were moving about and that they were okay and that they, that they were in the home and those sort of things. So there's different gradients of privacy that we can push with this. And there's little lights around the house. And you see those little lights are like night lights. And so when it's green, that means the camera's on, but they've given permission for that. If it's red, it means the camera's off. And if it's blue, it means it's in that privacy mode. So we have, those components of our technology. And of course, we talked about iLink Assist. What I love about our software is we've really married the ability to factor out times where somebody doesn't need help and pinpoint times when they do, like the stove is on, but nobody's in the kitchen or they've left the home, or, you can have reminders though, when an alert happens that can go to the person themselves. It can go to a family member. It can go to a professional neighbor. They get ultimate choice of what happens with those alerts. They can be a phone alert. They can be a text alert. They can be an email alert. And you can even make an alert, an audio alert, and deliver it to yourself, which is pretty cool. So iLink Assist has tailored alerts, but we all have this structure where you know when you have a need for help, it has to be answered. It has to be answered. So let's say that you have a preference. You really wanted to go into a neighbor of yours to help you. But what happens if that neighbor doesn't pick up that alert? Do you just let it hang and nothing? You know, I see a lot of iPhone SOS things where alert can go out to one of your contacts. But what if your contact doesn't do anything with it? What if they left their phone at home or they're in a meeting and they left their phone at their desk, right? Well, our system, if it's not answered, it escalates all the way to, at the end, it could be a call center. It could be your own call center, or it can go through, a professional neighbor and then go to a professional staff, somewhere that would answer, or an iCoach or things like that. All of ours alert escalate until they're answered, which is a really critical thing. So sensors, we talked about, advances all of those goals better than in-home staff. I mean, I would even tell you, would you rather have somebody in your home waiting for a fire, or would you more likely hope that you have a fire detector that could directly contact the fire department? Ask a fire marshal which one's more reliable, and he'll tell you. And then, of course, our software is totally encrypted and web-based. It's in the cloud, Amazon cloud, multiply redundant, HIPAA compliant. So, all those things are protections of privacy as well. And then the last thing, and guys, I'd like you to speak a little bit about this because I spoke really more than I care to, but this is the pyramid of support. Megan, Abby, would you like to talk about how does the neighborhood network arrange its supports and leverage, getting the best help for the best things?
Abby, do you want to go ahead?
Yeah, so the neighborhood network itself, the way we design it is we have the professional neighbors that are built around our individuals that live there. And they each have a certain schedule that they go by, and they have a certain caseload of individuals that they really work closely with. And they also work closely with their families. So we're working not only with the individuals we're serving, but with their loved ones as well. So now we have a team of people that are surrounding our individuals. I'll give a quick example of kind of what we can utilize the remote support for as well. We have an individual that has seizures, and she's highly independent, but she has those seizures, right? And she can usually feel them coming on. So what she likes to do if she feels them coming on before the night hits, she wants to go sleep out on the couch where she has some virtual support there. Let's say a seizure hits, the calling tree happens. So a seizure hits, we identify it through the software, through the sensors. The iCoach would then call the professional neighbor that's right there on site in their own apartment close to where this person lives, and they would be deployed within 5 minutes to help her. So that's a perfect example of how we can utilize all of the different systems to help this individual and be as independent as possible. And then on top of that, she has a brother that lives nearby that absolutely loves to be involved. The professional neighbor would then call the brother, and the brother could decide to come or wait till the next day or have a conversation with her. So now we have a team of people organized around this individual to help them maintain their independence and grow their independence.
And if somebody, Abby, hit the help button and say, "Hey, I have a need,"
right?
You would respectfully say, "Well, would you like me just to help you remotely, or you want me to drop over?" Right?
Absolutely, right.
So there's the organic choice.
Mm-hmm.
But they can also say, "Hey, I have a need, and could you call my brother to see if he could help?"
Right. They have all the choices laid out that we can cover.
Yeah.
That's that organic choice that's put in place, but we also have the capacity to do any which one of them, which is something I love.
And think of a senior who is trying to save money. And Megan, we all know seniors, they may even be affluent, but they're fairly frugal.
Yeah, I was going to mention the affordability of this approach because I think it's so smart. It's sort of like, isn't there a jingle now, like only pay for what you need?
Yeah,
right. So essentially the way that our care hierarchy happens, it along with all of everything we've talked about so far, there's this organic opportunity to utilize the most comfortable and least intrusive approach on the front end. So if it's something we can schedule, let's get it scheduled. Can we use a volunteer or a family member, a natural support? We will leverage everything we possibly can for typical community, for an individual's, individual need, and then add in additional support, remote support when we can do it. If we need to be in person, okay, do we have a natural support come and do that, or do we send a professional neighbor? And then I don't want to miss like the tippy top of this pyramid either. Really, because of the remote and enabling technologies that have been built in, we're able to bolt on and tap into nursing support, behavioral support, intensive behavioral support, perhaps a care coordinator. Any sort of clinical oversight can also just be directly applied to the individual in their home in the moment and place of need. And you see how we're able to scale the support based on what an individual requires in that moment, and with the most affordable, most appropriate approach to care. It's kind of unheard of. It's incredible.
What I
Well,
love that you said there was in that moment, because that's exactly what we do. It's in that moment we figure out what we need to do to cover the need.
yeah, and what I loved about it too is that you have a neighborhood care team, and that neighborhood care team it provides remote support and in-home. They do both, so they know the person well. So because they know the person well, they can do functional remote support in that home, and they're trusted. They have a relationship, all of those sort of things. But at the same time, you know, if I was trying to be affordable as a senior, I say, hey, I have some needs for X, Y, and Z. Could you see if my son can come by, this weekend and help me with that? Because if he can, it saves me a buck or two, right? That's what you want. You want to see, and from a son's perspective, I can't be there waiting, knowing what he needs. But I am all in to do what part I can do if it fits if I can make room for it. I can't
Well,
quit my job to do it, but I can work all around that. And all I want to know is if I can't do it, can somebody else do it? And that's
Right.
the hierarchy. It's like, ask me first, but if I can't do it, go up the tree and
yeah.
get somebody who can. And I'll then just pay for that part of it.
And how much better that you're able to do that wherever somebody lives naturally. They're not actually having to relocate into an assisted living sort of coordinated care, for lack of a better word, facility. We're able to deliver all of that robust support, scheduled and on demand, remote or in person, from your natural caregiver or from professional caregiver or from a clinical caregiver, right?
But with one
Again,
exception, Megan, we've taken a normal neighborhood and we've embedded a care system within it. So you couldn't necessarily do this you can organize natural supports anywhere.
Sure.
But if you're going to deliver, if you're creating an assisted living facility virtually in a normal neighborhood, organizing the care, you need to have the care team, the neighborhood care team, and we're going to talk about who that is in a bit. But we got to have that neighborhood care team, and we will deploy the family when we can, and when we can't, if it's urgent and they can't wait, then we'll do it with the neighborhood care team. And if they need a professional, one of the beautiful things that you were mentioning, Megan, that professional clinical group, they support multiple neighborhoods. So we're not just doing a clinical team for one neighborhood.
Right.
We're doing a clinical team that might support 15 of them.
Right.
Yeah. Abby, I have a question. Real quick. I've seen you in action in the neighborhood network in Johnson County, and it's impossible not to be impressed by how connected the people are that live there, how everybody is reaching out to help other people or to be helped. And I wanted to ask you if you feel like people really are connected while maintaining their independence in the neighborhood network in Johnson County, because it reminds me of something. If you agree with this, um, the are you familiar with ikigai? Ikigai is a very sexy concept right now It's there was a book that came out a few years back called Ikigai: The Japanese Secret to Long and Happy Life.
Mm.
And Ikigai is kind of a aggregate concept, a philosophy, if you will, that is basically trying to describe bringing meaning to one's life and thus making this person healthy and happy that way. And essential part of Ikigai is connection between people,
Mm-hmm.
with neighbors, family, friends, and so on and so on. I see so much Ikigai in the neighborhood network. There was the author of the book that's very, very popular right now. He's a Spanish guy from Spain. So he was impressed by the blue zones, which we are trying to create.
Mm-hmm.
And he decided to travel to one of the blue zones, a little village called Ogimi in Okinawa. That's one of the blue zones. The village Ogimi is known as the village of longevity. And he researched 100 elderly people who live there on Ogimi. And all of them reported about Ikigai. All of them said, you know, we're happy and healthy and living a long life because we find connection with other people. We find ways to volunteer. We try to be helpful and be helped. But what really amazes me is that our iLink is maybe another level of Ikigai. It's a technological Ikigai that helps us further that connectivity between people and neighbors and create yet another network. And uh, basically, I think both the words neighborhood and network fit within the description of Ikigai.
That's fabulous, Evo. I love that. And you know how much we focus on blue zones. I mean, you got to
Yes.
have big goals. And, you know, like all of our goals are driven by like, we can do Bewitched. We can create Bewitched. We can create a blue zone. Let's not, you know, let's like study these things. How does Amazon do it? How does you know Netflix do it? How did they become bewitched? You know, we look at those other things for inspiration, and we learn from them. You know, I think this is a combination between all of those things and Norman Rockwell. You know, in my day, you know, it was still the same thing. If you saw every painting of Norman Rockwell, it was exactly what you said. It's connectivity. It's the power of neighbors, the power of neighborhood, the reality that you may need help, but you can still help. You know, it's
Yes.
that's where purpose comes in. There's
You know, and
so
the
many
connection,
values here.
the connections at the neighborhood network are so strong because we're allowing them to guide us on how they want to be connected, and we're meeting them where they're at. And it takes it even one step further with the care team that we provide is we can deliver the services the way they want them, also even by a preferred person at this point. Like we can go
Yeah.
all the way up to that tier where, hey, I want this to be in person. And actually, could it be this person? Because we really connect in this way. And yes, absolutely, we can do that because we have a
Well,
care team in this network that we've
well,
developed.
we're going to power forward to, you know, to get through some stuff because I want to be done soon. But I do want to mention that, you know, when you are working in a single home as a caregiver, you must be everything. You must be you may have to help people do their finances. You may have to clean the house. You may have to cook the food. You may have to do complex care. The truth is, and then by the way, all of a sudden there's turnover. So you have no historic memory of anybody and you start again and you're supposed to do all that. And we know that's why it doesn't work. One of the beautiful things about, organized care is you can specialize. And I want to talk for half a second. I'm going to go on to the care team, and I want you to talk for a moment about the professional neighbors because this is a big deal for two reasons. One is we professionalized the caregiver to a very high level. We paid them really well because of how we're designing the system, but they're not working alone, and they're allowed to specialize. Like you have, like maybe in your neighborhood, we may have 4 or 5 professional neighbors among other staff, but those professionals may have a caseload, so they have certain people they're closer with, right?
Right. Correct.
But they also, some of them specialize in logistics. Some of them specialize in budget. Some of them specialize in arranging clinical services, right? Don't you
Correct.
specialize?
Yep. Yes. Yep. We
So
specialize
you
all of our
couldn't do that.
professional neighbors.
Yeah.
And they're considered
You
managers too, and people step up to the plate when they're a manager. You really get a
Yeah.
different breed of human and different quality services.
Yeah. So a professional neighbor, just to be real clear, they live in the neighborhood permanently. They work a 3-day work week, right? They're on call at night in case somebody needs help at night. But the theme on it is there's somebody remotely supporting that 24/7 because you need to know when somebody needs help. So it's a combination of remote support, assisted living, or sort of assistive technology, smart home technology, and in-home support that ebbs and flows around people's choices and organic needs, just like that. You couldn't just do remote support without the in-home. You can't do the in-home without the remote, because if you don't have the remote, you don't know when you need to be where. So it's an ecosystem that requires both to deliver care that effectively. And professional neighbors, not only we pay them well, they are full-time, they work 3 days a week, they're on call at night on a rotation, right?
Correct. And that prevents some burnout too.
But since it's sort of an organized neighborhood, it's more like a virtual facility in essence. So you can now have specialization because you're not doing it just for one home. You can specialize. You can have people become experts at things. And let me
Correct.
tell you, the most complicated thing in the neighborhood network is logistics, isn't it?
Absolutely. Yes. Because they're living a very independent life, they're making all the different choices every single day of different things to do.
Where do you go? When do you need to be there? Who's going to pick you up? Who's going to drop you off?
I want to go to Target. I want to go work out. Right.
Yeah.
Yep.
And
That's how we
you're
want
not
it.
wanting to do that by themselves. You've got to coordinate with all the other needs out there. So that's a real logistics, issue, but you can do that. So, and then the professional services kind of in ending, we can just bolt all of that on, but it's so cost effective because we're doing it across multiple neighborhoods. You're not trying to do it within a small home. You're making it available, and we're bringing it to them. They're not coming to our clinic. We're bringing it to them when they need it. I want to show you this before we go out into impact. And we're going to end on talking about impact. But this is a normal neighborhood. I want to give a picture of it, Abby. This is, if the blue there is just typical residents in a normal neighborhood, a picture of a normal neighborhood. And let's say in that neighborhood is some people with IDD, right? I mean, people who may have some intellectual disabilities living in the normal houses in that normal neighborhood. Here's something else. That's the seniors. Did you know almost every neighborhood, 20% of them are seniors trying to age in place? And then the gold is the professional neighbors. All we're doing is we're taking all the needs in that neighborhood, literally, as you know, our goals are inclusive populations, all neighborhood need, organizing it and delivering it 24/7 around needs using a live with, live near, live by options for our professional neighbors based on the level of needs and the complexity of care that has to be delivered. So we can serve a fairly wide range of needs within a typical neighborhood, which for seniors' perspective keeps them out of having to leave their home to go to assisted living. But I will tell you one thing. I always give this anecdote before kind of going to impact, and that is, we started this all off by just working with people with intellectual disabilities, and infusing them into a normal neighborhood, organically infusing them into it. Like this particular one may have been a neighborhood for 2,000 rental units, like a big development of apartments, and maybe 2,000 typical people. And we're infusing people with disabilities in there, and with apartment 20,000, 2,000 apartments. There'll be about 12 of them come due every month that you could actually move in. So we kind of infuse people with intellectual disabilities, and after doing that, for about 6 months, I got a call from the developer. Doug Price was his name, and he said, "What are you doing?" And I was like taken back by that, because that's all he said. I'm Doug Price. I own this development. What are you doing? Because GoodLife was guaranteeing some of the leases because they couldn't afford it. We were giving them access. to those places. And I said, well, this is what we do. I explained the neighborhood network, how it worked. I was thinking, well, is he going to not be happy with this? What's he going to say? And he got really quiet, and he finally came back and he said, I have a son with autism, and I've always wanted something like this for my son. So I'm really excited for this. And, as you know, 8 months or so later, we got a gift, a large gift, a pledge for $1 million from his foundation for our neighborhood network. And when he told me about that, he said, this is a special gift, but I'm going to give you some advice that's worth more than this. And I go, well, I'm all ears. What's that? And he said, well, 20% of the people, 25% of the people that live in my neighborhoods are seniors. And I don't provide services for them. They all have to leave at some point if they need care. And if you would expand your neighborhood network to this population too, then you would be doing an incredible service. Is that possible? Because I have 55 plus communities, but they don't want to move to the 55 plus. They want to live right here. And of course, that immediately changed our business plan. And now that's what we're doing. We're moving to a whole different generation of care where we're meeting the needs of everybody organically in a normal neighborhood, which is about as normal as you can get. And I want to point this out. There's software out there. I'm not going to talk about the details of it, but it's census-based software, and it has a lot of socioeconomic, economic, and age components to the software. You can determine in all communities, like those little squares are like little zip code squares. And the red is the highest density of seniors. So if you wanted to develop a neighborhood network where people are already living that have needs, you can find out where they likely are. And then you can market to them and say, we have a neighborhood network and you're in it. And you can get care as an amenity of your neighborhood now, and you only have to pay for what you use. They may not immediately want that, but we've now implemented our safety net program where we really just put the system in very affordably. And then when they need it, it's kind of like OnStar, they can have it. So let's talk about impact. Megan, you spent a lot of time on this, I know, but and so do you, Abby. But the neighborhood network, it has tremendous impact. It overcomes all of the barriers for in-home care that we've talked about. It helps us fill gaps in care that other people can't fill organically. So, when you're talking about the workforce shortage, it's one thing if you say, look, here's how we used to approach it. If I had an intermittent need, or my parents did, they had a need, they were 90% independent, but they had to get help 10% of the time. The problem is that 10% was unpredictable. So they ended up losing 90% of their independence and had to move to assisted living for 10% need, right? Well, in the neighborhood network, you can leverage family to do all that they can. And then you are since you can actually deliver care when the need is, even if it's unpredictable, you are able to fill the 10%. You don't have to have somebody lose all of their independence.
This is so smart. It's so smart because the reality is our health system can't keep up anyway with aging adults. And so we have to look at ways to leverage sort of the filling of the gap rather than just trading 10% need for 100% sort of dependence on the healthcare system.
Yeah.
It ends up being a win-win-win. And you'll see from the impact that we talk about, like it's a win for the person served. It's a win for their family. It's a win for the provider. It's a win for the caregiver. So yeah, it makes a lot of sense.
And let's dive into that a little bit, but it does, at the whole, it advances on the person's self-direction, independence, privacy, and removes the complication for accessing professional support. It really gives them access to some things organically. So here's for the person served. You can speak on this forever, Abby, but there's a lot of benefits. They get to live in smaller homes. They get care only when they want it, like Bewitched. They have more privacy. You can only use full-time staff in the neighborhood network, right? You don't use part-time staff.
Correct. Just full-time.
And they're all working 3-day work weeks. That means that they're off like 17 days a month and they're working 13 days a month.
Do you know
That's
how
a
many
pretty good
people wanna
life.
come in more? I mean, I've never had it that way before where they're like, "Can I do another day? Can I do another day?" I mean,
Yeah.
that's an amazing model that we've created here.
Well, I will tell you one of the things I know because we researched this is a 3-day work week works 13 days. They're literally off 7 months a year, a 3-day work week. And, they are off a lot. They will work 2 more days organically a month than what they're hired to work. So they are averaging 40 to 41 hours a week, even though you hire them for 36.
Yes.
A 5-day work week, you hire them for 40. The national average from our research is 32 hours. A 5-day work week is working 80% of what you hire them to work. A 3-day work week works 106% of what you hire them to work. That's incredible capacity. Plus, you got fractional care system, and you're not having to hire part-time people. The world, the rest of the country uses about 50% part-time to deliver fractional care. So it's just incredible.
Mm-hmm.
Person served, they have more stable staffing. We've had great employment outcomes for the people with intellectual disabilities in that. They get to volunteer, high satisfaction. This is one of the things I'm most proud of. This was a survey that was done independently where the individuals themselves got to rate various things in the program. They felt that, 82% felt they were more independent with the technology. 64% would say, I would need more staff if not for this technology. 87% experienced greater privacy because of the technology compared to traditional care, how they used to be served. 91% were self-directing their own help. 91%. 91% feel safer in their homes. 94% have a greater choice and control over their services. And 93% are satisfied with the opportunities and places they can go. It literally has advanced all of those things and privacy, which was just really cool. And that's not us saying, that was an independent group that came in and asked them privately what they thought about the program. Now, DSPs, though, that's cool. 3-day work weeks, that's unheard of in our industry, where base pay is $19 to $20 about $19 an hour, $18.50 if you look at the averages are out there. But professional neighbors get their home as a gratuity of their job, and it's tax-free. So they're fundamentally making very close to $30 an hour, but it doesn't cost us that because we only use them at night when we need them.
Mm-hmm.
And then they work full-time through the day. So we're really able to leverage our costs incredibly while giving them more. And, they want housing. They want to work from home. We gave them all the things they've asked for. And by the way, we pay for premium pay, time and a half for working Saturdays and Sundays, even all of that. So very cool. And by the way, we, just as all good behavioralists do, we look at what do the DSPs want? And we have designed the neighborhood network to try to give them everything that they want. And everything you see up here on the screen, flexible schedules, because we let people trade the front and the back, trade those 3-day work weeks with other people that trade. They have more days off and better days off. They have housing and housing. We're working on transportation. That's a whole nother goal. We're working on an Uber system for direct support system. Ability to work extra, but without the requirement to work extra. We don't require them to. We don't need to. We have plenty of capacity. They have work-life balance because they get to work from home and they have plenty of time off. They work close to home, obviously, and we pay them weekly, but we allow daily pay if they want it. And then we provide them useful benefits, which could be a whole nother discussion, and Megan will have that sometimes because that's her specialty. So at the end of the day, fractional care, and I call fractional care is gap-filling care. A little hours here, a little hours there, all over the place. With remote support combined with human support, the cost of care goes down. And if it's traditional support, the cost of care goes up. It's just that simple. But more importantly, there's no way to deliver intermittent, unpredictable care, fractional care without remote support. There's no way to do it. And we, as you know, Megan, we work in Alaska, we work in Arkansas, we work multiple states. I will tell you time and time again, I talk with managed care companies that aren't able to deliver even half of their authorized hours because there aren't staff available when the need exists to do it.
It goes back to that affordability. We're not going to pay any more to have staff sit and wait for needs. So what do? You either send them to a facility where you congregate people with a lot of needs, or you leverage what remote support can do now.
So technology can have a neighborhood network, but at the same time, Megan, traditional services can redesign what they do without changing everything to benefit
100%.
from technology. They can have, night support. They can do remote health. They can do remote behavioral support, service coordination. They can help train new staff remotely. They can help individuals. They can do so much with a great platform of technology. You don't need to have a neighborhood network to improve your care outcomes with technology. But we designed the neighborhood network to see how far we could go. And as we're learning, it's just the start. It's just the start of where we're going. Evo was talking about the end game. We're gonna be a blue man group here. we're gonna be the blue man.
Yes.
So look, we've ran this episode as far as we can. We've gone through last time the privacy paradox and how all of that works. And today we've kind of shown you an example of how we can create bewitching services where you can magically have them appear and organically around your choices, and that can advance all the federally required expectations of care better than traditional services. And because of that, they're in this hierarchy right now. I mean, that if we're being responsible, we should pick the least intrusive, appropriate approach for care. And it becomes obvious, but not obvious unless you compare it to what you were doing before or would do if you didn't have this. Now, the next time we get together, I'm going to do the craziest thing I can possibly do, probably something that's going to get me in trouble. And, I've gotten in trouble before. So you guys may want to hang around and keep me out of it too deeply. But I feel compelled to do this. I'm going to look at some policies from some pretty large places and go over camera uses and technology uses where they give helpful, sort of policies that they put together. But not one of them actually required that they would do the least intrusive, appropriate approach to care, even though I would ask every one of them and say, is that your goal? Well, of course it is. But they tried to regulate something that changes as fast as I could say that sentence, which is technology. And the truth of the matter, there is one, I keep going over this and I'll end with it. There is one principle that evolves at light speed with technology. And that is, if you only keep your eyes on using the least intrusive, potentially appropriate approach for care that can best advance the care outcomes, you will always be adjusting it to the best practice. And it will adjust as fast as technology adjusts. If you don't do that and you try to say, okay, here's what a camera is, and we can't use cameras, well, then you're not going to have angioplasty anymore. And we're going to have open heart surgery. You didn't mean for that to happen, but that's what's happening. We are confining people to more intrusive approaches because how we're trying to regulate technology. And I'm going to give you some examples this next time. And we're going to go into Dave's world, which is the wonderful world of it's not really a camera anymore, right?
It definitely is.
So that's happening next time. So anyway, enough of today and enough of this session. But it's taken us all the way from where we were last session through like a look into the future of services, and hopefully from this vantage point where we already are right now, we realize we're not even close to where we want to be, which is really crazy because none of us could have imagined 10 years ago that we're here. Right? So it's pretty cool. That's what I love about the quest for the good life is once you're there, you see something that you want to go to. And it reminds me of that thing I'll end by saying, you're either a pioneer or you're a settler. And I don't want to be a settler. I want to be a pioneer. So there you go.
All right. Well, this was yet another bewitching episode of the Quest for a Good Life with Dr. Mike Strauss, the only boss who we wouldn't mind visiting us in our home rather than remotely. Today, the only one though. Today, we continue to decipher the privacy paradox by visiting the award-winning Neighborhood Network with Megan Todd, David McDonald, Abby Baden, and of course, Samantha the Good Witch. I was your co-host, Ivo Ivanov. The episode was produced by Alex Escalante. Until next time, this was the Quest for the Good Life.